when you don't have that knowledge, when people haven't explained these quirks to you, you think, what fresh hell is next in terms of random weirdnesses?
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes, dedicated to helping you navigate hypermobility and live your best life. I am so excited to speak with Dr. Jessica Eccles today. Dr. Eccles is an award-winning neurodevelopmental psychiatrist and researcher specializing in the links between the brain and the body, and particularly joint hypermobility. Dr. Eccles is a wealth of information, so I know you're really going to enjoy this episode today. As always, this information is for educational purposes only, and it's not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. I'm so excited to be here today with Dr. Jessica Eccles, who is an incredible expert in the space of hypermobility, connective tissue variants, neurodiversity, so many amazing topics that are so critical to this audience. And this is our third conversation with Dr. Eccles. And I know that the first couple of conversations were, at least for a very long time, some of the absolute most popular episodes of the Bendy Bodies podcast. So it's a real honor to have you back.
Oh, it's a real pleasure to be back. Thank you so much.
Of course, of course. So I have to say, in preparation for this episode, I was looking at more recent articles that you've published. Oh my gosh, you're talking about so many different fascinating things, right? And I'm like, wow, we're talking about, of course, neurodivergence, hypermobility, chronic pain, fatigue, all these things where people are being told that it's all in their head, and the difference between things in the body, things in the brain. And it was also really interesting because I will be soon interviewing Dr. David Nutt
wow.
And Lucy Stafford. And so it was funny because I was preparing for both interviews at the same time. And I'm going to talk to them about psychedelics.
Yes, because Lucy was my master's student, and she was working with David Nutt on medical cannabis for EDS. She's now our PhD student at Brighton and Sussex Medical School, and she's working on a technique called microneurography to look at single nerves as a measure of autonomic nervous system function in postural tachycardia syndrome and hypermobility.
Wow, that's amazing. Well, it was funny because I didn't think there was necessarily any connection between the three of you. I knew there was between the two of them because he suggested that she be also, a guest on the same show. But then I found an article that the three of you published together. So that was cool on medical cannabis. So you are doing so many great things. And it's like, okay, well, where do we start? Maybe we start talking about people being so misunderstood and the distress that they experience. And I feel like this is just so common. It's kind of a common thread through the work that you're doing. People are often misunderstood when their distress is intense, embodied, or hard to categorize. Do you see that as one of the central issues for people with, connective tissue variants? I love how you call it connective tissue variants, postural orthostatic tachycardia syndrome, et cetera.
I think that this is absolutely pivotal, really. So there was the Halverson paper a couple of years ago about clinician-associated traumatization in EDS. And I give a fair number of talks. I think, in fact, last year I might have given 50. And one of my new talk styles is to talk about some of the things that I was interested in before I became interested in psychiatry. So in medical school in the United Kingdom, it's different to in the United States. So I think in the United States, you do an undergraduate degree and then you do medicine afterwards. Here in the UK, we go into medical school when we are 18, and it's an undergraduate degree, but it lasts kind of 6 years. And one of the things that certain medical schools do is they let you do a little mini degree in the middle. So I did one in a relatively unusual topic, you would think, called the history and philosophy of science. This was back when I was at Cambridge University. And I found an old essay that I had written back in those days of being a slightly pretentious undergraduate. And it was about the social construction of healing. And it basically said that for a coherent doctor patient relationship, for healing, which I kind of use in a grand sense, to happen, you need to have a shared narrative, a shared framework. And I think for so many hypermobile people, this is what they do not get. So they go and see a doctor, they go and see any number of professionals or educationalists, and many of them, unfortunately, basically hear back, I don't understand your story, therefore it cannot be real. This must be somehow in your head, this must be somehow anxiety or functional neurological disorder. And that what is so transformative, and what I hope the research that we're doing, particularly at Brighton and Sussex Medical School, is helping, is to provide a framework that both seems coherent and makes sense to patients, and also by doing this research and by trying to educate other doctors and clinicians and the public, there is a shared narrative. And I think that that is really important, because without that sense of trust, of being listened to and being believed, I don't think you get very far in medicine. You need to at least have some sense of what we would say is singing from the same hymn sheet. You need to that there needs to be a shared framework and a shared language. And this is why hypermobility and variant connective tissue are so interesting, is because they involve both the body and the brain, and the work that we're doing is kind of connecting all sorts of things that seem in some ways quite disparate, anxiety, chronic fatigue, ADHD. You might think, well, how are these all interrelated? But actually, by providing this framework, you are able to say to patients, and I am a patient myself, that you haven't actually got 10, 12 different perplexing problems that no one understands, seems to be random, you might be making up. In fact, there is this unifying framework. You are built differently. And by being built differently, you may be more likely to be able to do certain things, like dancing, or you may be able to be particularly good at playing certain piano pieces. But at the same time as having those sort of strengths, you're also more likely to have a particular constellation of challenges. And what we are really realizing is that there is so much more we need to know, because I think the work that we're doing is really just the tip of the iceberg.
Yes, yes, I agree. And I interviewed Dr. Halverson for the podcast, so we're going to link that, and we'll also link that paper in the show notes that you just mentioned, because that's a really important paper. I've used that quite a bit in my presentations as well. It's important for people to be aware of and know that, for better or for worse, they're not alone in having had these traumatic encounters. And if we can really improve that, I think that's going to be something really helpful for so many people. And you've published on some interesting topics like rejection sensitivity, masking, chronic pain, fatigue, autism, and borderline personality disorder. And I'm curious what ties those together for you.
Well, what ties them together? Now, I must caveat the idea of borderline personality disorder as a sort of somewhat contentious construct that I don't necessarily agree with, but it's a diagnostic terminology, all of those things are linked, as I think almost everything is, with variant connective tissue. So rejection sensitivity is a very interesting topic in that it almost seems to be, or it's really exploded on social media. There's lots and lots of people talking about it on social media. I remember first reading about it in, is it Hallowell's book, Delivered from Distraction, which was a book about ADHD. In the book, he describes one of his patients, basically kind of waiting for, what fresh horror is going to happen next that's going to basically take the rug out from underneath my feet and make me feel awful, and that this is me living every day. And when we started looking into rejection sensitivity, it actually turns out that rejection sensitivity is not specific to ADHD. The previous research looks at rejection sensitivity in autism as well, and also in self-esteem issues and in depression. I do not think rejection sensitivity is specific to ADHD, but for people with ADHD and neurodivergent people, people describe typically that one of the things that is hardest for them is emotion regulation. So even though we think of ADHD as a difficulty in focusing, when in fact actually it's a difficulty in switching focus, it's not necessarily a difficulty in focusing. One of the things that adults in particular would like to change the most about ADHD if they could is this sort of roller coaster of emotions. And again, it kind of takes me back to what I was saying about the shared framework, is when you talk to patients about rejection sensitivity, whatever their diagnosis, and also it could be related to trauma, it could be related to self-esteem problems, it is something that patients really seem, some of them, to identify with. So this feeling of feeling profoundly upset, disturbed, depressed by the thought of actual rejection or perceived rejection. And so when we started looking into it, we noticed that actually, although lots and lots of people are talking about rejection sensitivity, there is very little understood about it. So we, in parallel, have been doing two projects, one of which is now published by Annabelle Smith and Beth Sutton and Lisa Quat, our qualitative exploration of rejection sensitivity. But with Rebecca Gazet and Lisa Quat, we are doing some quantitative work as well, which is also very interesting. But the big finding that we found in the rejection sensitivity paper, the one that I found most interesting, was that this experience of rejection sensitivity is basically an embodied experience. So the people that we talked to, or Annabelle talked to whilst I was there, they said that this feeling of rejection was like a punch in the chest, that it was like having a chair pulled out from them. And it just goes to show that what we think of as a psychological construct, difficulties related to self-esteem and relating to other people, is we cannot separate that from the bodily experience. And this links to how the work that we've been doing in hypermobility, the very early work that we did in hypermobility and anxiety and autonomic dysfunction, so what you might see in postural tachycardia syndrome, is that a hypermobile person may be more likely to be neurodivergent. A neurodivergent person, for a number of reasons, may be more likely to be traumatized. And this hypermobile neurodivergent brain body, because of the reactivity of the autonomic nervous system, may well then process trauma differently, more acutely, leading to this embodied phenomenon. The reason why I think this is important is that, especially for a lot of people who have difficult relationships with their bodies and their brains, so there's this this idea of in neurodivergence of, well, not in neurodivergence, there is an idea in neurodivergence of alexithymia, which is this difficulty recognizing and understanding emotions. And there is also, we've been working for many years, particularly Hugo Critchley and Sarah Garfinkel and Lisa Quat, on this idea of interoception, the inner sense of what is happening in your body. And for those of us who have complicated relationships with our bodies, they're prone to do things they shouldn't and let you down. Actually, sometimes the body might be the way in to integrating the brain and the body. So if you are very, in a rejection sensitive moment or in a traumatized moment or a triggered moment, you will potentially become dysregulated and distressed. And when you're dysregulated and distressed, actually talking about it doesn't necessarily help. It seems, you think, oh, we've got to let it out, we've got to talk it out. But what may help is getting in tune with the body through sort of the senses may get you into a sort of a zone of a window of tolerance, a zone of regulation. That means that you can begin to do some work that calms and settles the both the brain and the body. So I think that the rejection sensitivity work, the embodied nature of the rejection sensitivity, it ties up with my other, I think, I'm not sure if it was last year or the year before. I think it was last year. My favorite paper that we have published, not supposed to really have favorites, is I think it was called The Proprioceptive Impact of Neurodivergence on Emotion Regulation and the Relationship with Joint Hypermobility. It's a bit of a long title, but essentially what we showed was that if you had neurodivergent characteristics, you were more likely to experience emotion regulation difficulties. And that emotion regulation difficulties were related to this sense of uncertainty about where you were in space. We called it proprioceptive surprise. But that relationship linking the brain and the body in terms of emotion regulation was, in fact, twice as powerful in people with joint hypermobility. So this is the sort of paradox that we see in hypermobility is like, dancers who might bump into walls, that this sense of uncertainty about where we are in space may in fact be contributing to mental uncertainty. And that if we, and this is just a hypothesis on the basis of this data, is that if we were able to improve our proprioception, quite simply sometimes, I don't know, wobble boards, resistance bands, arch supports, just feedback, it might be that by improving our sense of certainty about where we are in space, could in fact improve our emotion regulation, which I don't know, somehow that really, I love that idea because we know, and I'm a psychiatrist, that conventional medication strategies and conventional psychological approaches, they don't work for everyone. And this basically just gives us something more, another tool in our toolkit, and opens up an entire avenue of brain, body research and possible interventions that I don't think we'd necessarily been thinking about before. Or if we had been thinking about, we didn't have evidence to necessarily support.
I love that because I totally see your point, and my personal and professional experience also is completely consistent with what you're saying about emotional dysregulation, and that in that setting, talk therapy may or may not be that effective. And I'm also thinking about the rejection sensitivity, and that might help explain why so many of us are subject to gaslighting ourselves. So we go to the doctor and we get this rejection by the doctor. The doctor says, no, 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 there's nothing wrong with you. You're perfectly fine. I did some lab tests. I did an x-ray. You're fine. So then we sense that rejection, but we internalize it. And if we have problems with emotional regulation, that can really set us on a bad path that maybe some other people, it just wouldn't faze them as much.
No, absolutely. And I think that's the interesting thing about rejection sensitivity is that it manifests in different way for different people. So for some people, just as you've described, you can internalize it. But I think rejection sensitivity can also be externalized as anger, as rage. Some people may withdraw into themselves, and other people may move towards other people. And what though is really hard, I think, when I speak to my patients in our neurodivergent brain body clinic we have in our NHS service in Sussex, the world's first neurodivergent brain body clinic, is that feeling of rejection, that feeling of being misunderstood, that feeling of being let down, or means almost like a feeling of learned hopelessness and helplessness. And that there are many patients that I talk to who have all sorts of issues who actually don't want to put themselves through the fear of going to see the doctor or a healthcare professional because they are worried, very worried about being misunderstood. And not only is that leading to this sort of sense of hopelessness and helplessness, it could actually be really dangerous in terms of not seeking help when you need it. I mean, we know obviously that there's lots of problems associated with hypermobility and with things like postural tachycardia syndrome, but that in the main, apart from for the genetic causes of Ehlers-Danlos syndrome, they don't tend to be life-limiting conditions. And, postural tachycardia syndrome is not a problem of the structure or function of the heart, but not being believed may mean that you end up not seeking help for something that is actually understood or more widely understood, like the signs of a cancer or heart disease. And that is really, really sad. The other thing I just wanted to say there about rejection sensitivity, and we don't have a really good construct for it yet. And I really don't think there has been much research. But one of the papers that we just had published only a few weeks ago, actually, was about the relationship between hypermobility and bipolar disorder and neurodivergence. And this was something that these Swedish studies, we've got, these whole population databases, I will have talked about this before on the Bendy Bodies podcast about how the Swedish data showed that if you were hypermobile, diagnosis of hypermobility, you were 7 times more likely to be autistic, 5 times more likely to have ADHD, but also 3 times more likely to have bipolar, and unfortunately twice as likely to have attempted suicide. And we showed in a group of patients with a bipolar diagnosis that they were more likely to be hypermobile, and that the relationship between hypermobility and these altered mood states was partly driven by neurodivergent characteristics. And if we think of rejection sensitivity as a sort of a gateway or a driver into depressed or low mood or dysphoria or burnout, we must also think of the opposite. You know how neurodivergent people can get quite excited, busy, a sort of glimmer. I think we talk about things that give you joy. That there is also this the converse to rejection sensitivity, recognition sensitive euphoria. So this overarching idea that of all of these paradoxes, that you don't want to be overstimulated, you don't want to be understimulated, you don't want, you are trying to live in this, this sort of sweet spot, which I refer to one of the very first books about by a patient about hypermobility that I read, back in, I don't know, 2010, 11, was called Bending Without Breaking by Isabel Knight. And I really, I don't know, like that analogy as a hypermobile person. How do you learn to bend physically, mentally, without breaking? How do we, how do we live within our, how do we live well within our limits?
Yeah, that's obviously really challenging for a lot of us. And that's really interesting what you said about the recognition, sensitivity, euphoria. That's super interesting. I've never heard that term before. So that's fascinating. And a lot of people who you just mentioned about the Swedish study, which I find fascinating, or the database that they collected. And we talked a little bit about autism and how much more common that is. Can you talk a little bit about masking and what
Ah,
should
yeah.
cli- yeah, what should clinicians know about masking and what should patients know? When is it protective? When is it harmful?
Well, this is a really interesting point, and that's also cropped up in the rejection sensitivity business. Was this idea of masking as an important defense mechanism? So masking, we often think, because when I was at medical school, long time ago now, I told that autism and ADHD affected males 9 times more than females, and we now know that that difference is probably minimal and may not even exist at all in terms of the gender differences. But one of the ideas that is put forward is that women in particular, though not necessarily just women, are not picked up as being autistic or having ADHD because they learn to have a mask of, maybe social competence, so have a social script. They're sort of performing in social situations, or that they can be in social situations, but they actually find them quite draining or exhausting, and will have to spend a lot of time recovering. That people may be, naturally quite hyperactive and fidgety, but they will mask that and suppress that. And to a degree, we do need to, in certain ways, to mask a little to get through the world. But at the same time, masking may come at a considerable cost. So it may be energy draining. It may also be, it sounds like a strong word, soul draining. It may take not only a toll in terms of energy, but it may kind of take a toll in terms of its identity, of your identity. Who am I? What is underneath the mask? But at the same time, masking masking may have a function. And I did talk on this other podcast, the ADHD Chatter podcast, about ballet as an analogy in some ways for this. I know you're very interested in dancing, and I actually, I can't dance to save my life. But you have this beautiful performance of dancers, and in some ways that is a mask underneath that beautiful performance. Poor dancers' toenails are like probably dropping off, and really dealing with very difficult injuries and problems. But the show has gone on, and but that takes its toll. But at the same time, it's all jumbled up. And one of the interesting things, though, is I'm the patron of a charity called SEDS Connective, and its founder, which is a charity particularly for hypermobile neurodivergent people. And when I was talking with Jane Green, the founder, and she said she wasn't quite sure about this masking business in neurodivergence, but what she really knew and understood in a kind of bodily level was that as a hypermobile person, she had gone through her life basically masking pain, which I don't think people actually talk enough about. We talk about masking a lot in autism and ADHD, possibly other neurodivergences, but this idea of being in a body that is unreliable and going to let you down. And she talks I have a YouTube channel, Bendy Brain, and we interview her for episode 3. And she talks about how she'd go to the doctor, and one time it'd be like her left leg that was out of whack, and then one time it'd be her right leg, and they'd be like, "Have you even forgotten?" And she's like, "No, no, I'm being affected on different sides at different times." And that when you're so disbelieved, or you have to keep functioning, she was talking about having to, look after her children, that you end up masking that. And I kind of had a strange realization myself. I'm 43 3, I have a condition that is associated with hypermobility. Used to be called congenital dislocation of the hip. It's now called developmental dysplasia. So I had a, improperly formed, well, absent hip socket, and lots of surgeries when I was younger, and probably started experiencing pain from early onset arthritis when I was about 9 or 10 years old. And that pain didn't really, well, obviously it didn't go, it just got worse and worse. But it did leave when I was 36 and had a hip replacement. And unfortunately, in the last, I don't know, just over a year, I have had a lumbar disc prolapse, multiple ankle ligament ruptures, and some problems with my right hip, and some trochanteric bursitis. So I've been plunged into a terrible state of my wings clipped, can't really mobilize well, and awful pain. And I realized that, of course, I'd experienced all of that before, but I kind of put it away and forgotten it. And actually, having a taste of that again made me realize that to have got to where I am sitting here talking to you now with all of these research papers and stuff, getting through medical school, well, getting through school, getting through medical school, getting through, I think you call it residency and all of those things, all of the bits that you have to do to end up proper, fully fledged consultant, that I must have, in order to have done all of that, the only way of surviving it was to pretend it wasn't happening or not to show it to other people. So I agree with Jane in some ways that I don't think we talk enough about masking, but also that if you are a hypermobile person whose body is always letting them down and has let them down, possibly since before they could talk, you might not even realize that that's what you're doing, because you think that must be like that for everyone else. And that is such a common experience when I talk to my patients. You say, do you get dizzy when you stand up? Do you have to lie down after a hot bath? And they say, oh, but doesn't everyone? Like, no. And same thing with a number of patients recently with a quite unusual phenomenon, an immunological phenomenon called cold urticaria, which is where you kind of get hives and pain when you're in the cold. And sometimes people's, throats swell up, but you also get this really painful sensation when you put your hands in cold water. And bizarrely, I've had a run of patients with this particular problem recently, and they're like, "But doesn't everyone feel like that in the cold?" And you're like, "No, it is not normal to have your throat swell up just because it is cold." And there is this degree to which hypermobile people really end up putting up with experiencing so many medical strangenesses, but have no idea that these are not everyday experience. Particularly because hypermobile people tend to have hypermobile family members, and so it's sort of accepted as this is typical.
Yeah, and as you're talking about that, I'm thinking about how so many of these things occur on a spectrum, and if you're talking to somebody and you ask, "Oh, how are you doing?" So often we say, "Fine," right? We're masking, I think, is also, to me, as you're talking about this, probably on a spectrum. Like, pretty much everyone has to mask when they're in medical school. I mean, or doing, like you said, dance is a perfect example. You're trying to make it look so effortless, but it's really, you're in pain, it's really hard. So I love those examples. It sounds like what you're saying, though, is that people who have hypermobility, chronic pain, all of these other things, cold-induced urticaria, vibration-induced urticaria,
Yeah.
like these,
Yes,
again,
exactly.
yeah, we don't know what other people's bodies are like, and so we just kind of are trying to fit in, and so we just kind of, like, pretend like it's not happening.
Mm. But I also think that it is, but making sense of that, and it brings me back to what I was saying about this narrative framework, is when you think, oh God, actually, all of those things could potentially be linked, and that these unusual experiences, which I didn't necessarily think were unusual, are all connected, although that doesn't make it necessarily any easier to experience them. It having a unifying framework, I think, has a sort of sense of validation and a sense of meaning that you don't have if you haven't got a explanation.
Yeah, no, that makes perfectly good sense, and the fact that people, again, don't know what other people's joints feel like, so they don't realize that their joints are unstable sometimes, because if they're getting more subluxations than dislocations, they might not realize that other people walking around don't have to deal with that and aren't, coping with that. We're gonna take a quick break, and when we come back, I really want to explore your fascinating work on autism and borderline personality disorder. I really wanna talk about that because it's something that I think is not talked about often enough, and I know there's a lot of stigma attached to both of those, but you talked in one of your papers about that, and I think it's a really fascinating topic. So we're gonna take a quick break, and we will be right back with Dr. Eccles. Downtime at home should feel effortless, a quiet pause in your busy day. Cozy Earth's robes wrap you in softness with thoughtful details that move with you. I love the spacious pockets, adjustable ties, and cozy silhouettes that make every moment feel intentional. Each piece is made with such great care. And I also love their slippers. I love slipping my feet into them at the end of the day and finally exhaling. The footbed is so comfortable and makes my feet feel so amazing. They're really versatile, breathable, and cozy. I also love that Cozy Earth has a 100-night sleep trial and 10-year warranty, because the comfort you deserve should last just as long. Let this spring be a reminder that you deserve care too. Discover how Cozy Earth turns everyday routines into moments of softness and ease. Head to cozyearth.com and use my code BENDY for an exclusive 20% off. And if you see a post-purchase survey, be sure to mention that you heard about Cozy Earth right here on Bendy Bodies, because home care starts with self-care. So we're back with Dr. Jessica Eccles, and right before the break, we were talking about vibration-induced urticaria, and I was taking an exercise class this morning, and they brought in these, vibration plates, power plates, and I immediately, when I was standing on it and doing the exercises, I immediately started itching. But I think you have a even better example of vibration-induced urticaria.
So I was talking to a patient just a few days ago who had no idea that it was not typical to come out in a rash, so hives, and go red from from pressure, vibration pressure. So she found that clapping brought on hives, and she has a child, and you can imagine how often children want to clap and clap back, and how many times at, I don't know, primary school or elementary school, or that you end up having to clap. And but if you I think this also, it really feeds into this framework that we talk about in terms of prediction error and mismatch. So if you knew, Linda, when you obviously knew that you come out all itchy and stuff because of the vibration, but if that happens to you and you perceive it to be random, just as, you have heart rate spikes and you don't realize that's because you've changed posture or you've had a hot bath or you've had a large meal, those physiological signals are troublesome, overwhelming, scary, confusing. And in and of itself, that uncertainty and randomness is going to feel or even generate anxiety because it's so unpredictable. But once you have a framework for it, so you had the framework, but not many people have that framework, you're able to say, actually, I need to step away from this vibration plate or, seek medical advice about antihistamines or something. But, that means that it's slightly less scary. But when you don't have that knowledge, when people haven't explained these quirks to you, you think, what fresh hell is next in terms of random weirdnesses?
What fresh hell is next? That we're gonna have to for sure use that as one of our promotional pieces, because I think so many people can relate to that. What fresh hell is next? Yes, the uncertainty gets, there's enough uncertainty in life, right? Especially now. But having all that uncertainty in your body and not being able to count on your body being able to do certain things. is incredibly stressful and incredibly anxiety provoking.
And also when you don't realize, yeah, that, just as you were saying, that this isn't like that for everyone. So I had another patient, and it sort of sounds embarrassing, and I don't know what the cooking situation is in um in the United States of America, but in the UK and Europe, there is a sort of luxury brand of saucepans that are made of very pretty painted cast iron called Le Creuset. And these are high-end saucepans. And I was talking to a patient, and I said, "What would happen if you had to pick up a Le Creuset saucepan?" And they said, "Well, I would really struggle because they're too heavy for my wrists." And I think this could be, a new medical sign in the textbooks, the Le Creuset sign. But uh, my brother bought me one of these a griddle pan made by this same company. Very beautiful, powder blue, beautiful. Can I use it? No, I can't, because my wrists are too weak to lift it up. And when you talk to patients and say, when you come home from the supermarket with your shopping, does it feel like your arms are going to come out of your shoulder sockets? And they're like, yes, yes. But does this happen to everybody? No. Quite a few people are able to carry their groceries home without feeling physically on the brink of subluxation.
Yeah, no, it's hard if they've just everyday tasks cause you to get injured. I remember when I first read about kinesiophobia, and I was writing my first paper about pain medicine for people with joint hypermobility, and I came across the word kinesiophobia, and I realized, oh my gosh, that's what's happened to me because I kept getting hurt doing little everyday things, and so it has been very helpful for me. I'm very fortunate that I've been able to build more muscle mass, which is protective, of course. But yeah, when you don't have that confidence in your body that you're not going to get hurt doing little things, that's incredibly challenging. I want to go on and talk about autism and borderline personality disorder. So there's so much stigma around borderline personality disorder, but there also is around autism. And I know you wrote a really interesting paper about this recently. Can you talk to us about the overlap between these, why it's important for this population, especially what we might want to look at in order to distinguish which diagnosis is more appropriate and what we can do about it? And that, I know that was a lot all rolled into one.
No, but I think I got the gist. So yes, with colleagues, Sebastian Shaw and I supervised a psychiatrist called Bruce Tamilson, who conducted a number of interviews on, I think, mainly women. I'd have to go back and check the methods. I'm pretty
I
sure
think it
that
was women.
and these people had all previously received a diagnosis of is called considered in the DSM as borderline personality disorder in Europe under the ICD-11 classifications. This might also be called emotionally unstable personality disorder. And what it meant to them to later be given or confirmed as having an autism diagnosis. And what the sort of the bottom line, and it brings us back to what I was saying at the beginning about the framework, is that they felt the autism diagnosis made sense to them in a way that the personality disorder diagnosis did not. That uh, it provided a framework for understanding themselves that they had not previously had in connection to the personality disorder diagnosis. Now, this brings up a huge number of questions. I mean, the very first question also brings us back to the history and philosophy of science is, how do we know what we know? And in psychiatry, we have a lot of labels. We don't have markers in the same way as you might have in other areas of medicine. But you must caveat, in other areas of medicine, which do have biomarkers, those biomarkers and the definitions of those biomarkers and those ranges are constantly changing. So, what people consider to be high blood pressure 20 years ago is completely different. Now we know, for example, things like CRP, what we considered to be a normal CRP when I first was a junior doctor is now not the same as what we consider to be a normal CRP now. So biomarkers in and of themselves are a slight fallacy in terms of this is knowable and solid. Is that psychiatric labels? I remember going to a lecture years ago. Someone was describing the DSM. It's basically a Chinese menu. You pick a bit of A, a bit of B, and then there is criteria C. And that's not, this is the same thing in physical health, in lots of syndromes. You have major and minor criteria. And these diagnostic criteria have, for want of a better word, the great and good have sat round a table and sort of decided what they are. And are these diagnostic categories, well, are they actually consistent? They probably are, in that, thinking about things like ADHD and autism, as we understand it now. I don't know if people are familiar with Anne of Green Gables, but you only have to read Anne of Green Gables' Canadian novel about an orphan to realise that ADHD has been there forever, that we've been describing this sort of thing in literature. You only have to read Shakespeare to understand that people have experienced depression ever since people have been writing, but some labels seem a better fit than others. And I think that the thing about a neurodivergence description is that it captures things that a personality disorder diagnosis may not. So one of the big issues for neurodivergent people is sensory sensitivities. So feeling strange when your clothes don't fit you right, when there's funny smells, being overwhelmed by loud noises, or there not being enough noise. I like to go to a cafe sometimes to concentrate because a bit of noise, background noise, is actually helpful. We're all different in terms of our sensory profile, but the emotionally unstable, the borderline personality disorder label or construct doesn't include any of those things. It doesn't have a sensory element. It has a interpersonal element, and it has a harming, often, self-harm element. And I think it's important to recognize that some forms of, and it's difficult to talk about, some forms of self-harm may be actually attempts to regulate, a dysregulated nervous system. And if you're hypermobile and neurodivergent, you may be more likely to have a dysregulated nervous system. The other interesting thing is that the diagnostic categories, they lump things together. So they put things like, autism in a round, they put depression in a round, put personality disorder in a round, and they put, I don't know, psychosis in thing. But actually, all of these rounds are made up of sort of star shapes and spiky bits that are actually quite common in all of those things. So there are elements, for example, ADHD, bipolar disorder, and what you consider emotionally unstable personality disorder are all associated with problems with impulsivity and emotion regulation. And would we not be better to focus on characterizing the differences and responding treatment wise or intervention wise to those core kind of neurological, the neural construct of what is driving impulsivity and emotion regulation issues, than necessarily having these particular labels? And the problem for me with the EUPD or the borderline label is that it's a bit like a functional neurological disorder, in that these patterns may well exist, but that the label itself has become pejorative, even if it never was intended to be in the first place. I mean, people may not know, but the term borderline personality disorder actually originated back in a time in psychiatry when we were much more focused on a psychoanalytic approach to understanding people. Was there was an idea that there were some people who were neurotic, so they had anxiety problems, they had depression problems, and then there were some people who were psychotic, who had delusions and hallucinations, and that borderline personality disorder is the border between psychotic and neurotic. But people, when they hear the word borderline personality disorder, they do not think, oh, this is the history of the difference between neurosis and psychosis. They think this is a stigmatizing label that, and now this sounds possibly of a stretch, but it is mainly made by men on women, so male doctors, to describe a set of things in women that they find potentially problematic. So, for the people who took part in our study, they basically were saying that a autism diagnosis provided a more coherent and less stigmatizing account of their differences and difficulties than the previous personality disorder diagnosis. Now, what I am grappling with conceptually in a quite a big way, is it one or the other in the world? Is it either or is it both and? And I think we have to bearing in mind the caveats about what are labels anyway, what are our diagnostic constructs, is it is possible, just like people didn't think you could diagnose autism if someone had trauma, it is possible to for more than one thing to be going on at once, and we have to really formulate and integrate all of the different elements of a person and their brain body interactions. And I think helpfully, conceptually, I hope the term borderline personality disorder or emotionally unstable personality disorder is more into this idea of complex post traumatic stress disorder. And again, when I speak to patients, many of them, they find the idea of complex PTSD resonates in a way that a personality disorder diagnosis does not. But it's perfectly possible to, in fact, it's almost certainly more likely to be neurodivergent and also to have experienced complex trauma. There's a very, I'm looking forward soon, some excellent colleagues from Glasgow, which is in Scotland, are coming to brainstorm some work that we've been doing about the intersection between neurodivergence and trauma. And as I was saying, we know from Helen Minnis and Ruchika Gajwani's work that if you have experienced trauma, you are actually also more likely to be neurodivergent, and neurodivergent people are more likely to experience trauma. So I don't think we can get away from the idea that it's either one thing or another. But I think that neurodivergence can provide a framework that is helpful. It also, by understanding, what I was talking about in terms of sensory things, it provides a way, and this goes back to the proprioceptive uncertainty, it provides an opportunity and an avenue for regulation. So if you give someone a label of EUPD, that doesn't necessarily give you the tools to work with it. But when you understand about a spiky profile and your sensory differences, you can kind of work, you can move into understanding yourself better. But interestingly, there are a couple of techniques that are used, particularly in dialectical behavior therapy, which has been used for um, people with complex emotional needs, is this idea of putting something cold on your face. I don't know if you've heard about this, but I remember one of my patients saying that they'd been on a program called a STEPS program, which is something that's quite common in the UK, and that they've been told, if you're feeling dysregulated, that you could kind of put your face in some water. They said they didn't want to do that because they had a fear of drowning, but what they had worked out was that if they put frozen peas on their face, that did the same job. And my PhD supervisor and mentor, Hugo Critchley, he is very interested in autonomics and also reflexes. And what you are describing, what the patient was describing about the soothing impact of frozen peas on the face, is something called the diving reflex. So that activates a parasympathetic response that reduces heart rate. So that helps regulate because you are calming your autonomic nervous system down. So I don't think we should always necessarily throw the baby out with the bathwater. There are elements of interventions for what we call personality disorders, that are helpful for regulation. But I do think that we have to strongly consider on what basis do we have these labels, and are we better actually just describing a series of patterns? But I also think it's interesting because I'm speaking at this from a perspective from Europe, from the UK, where I think autism is still a very stigmatized label, but my feeling is that there is more stigma perhaps in the US, that Europe, well, that in the UK there is a more neurodiversity affirmative approach, but I could be speaking in overgeneralizations. But it is very interesting, hierarchies of stigma, because we think of stigma as a sort of stigma is stigma. But I remember when I was first a very junior researcher, I was researching, and again, this was actually brain body stuff. At the time, people who had a condition called hepatitis C, which is a liver condition, were given a inflammatory cytokine called interferon as a treatment. And this was a really it's a now an outdated treatment. There's something much easier and less tricky is used. But at the time, interferon had to take it for months and months and months, and it would make half of the people who took it depressed or cause real psychological difficulties. So we were looking at why some people might be more likely to experience interferon-induced depression if they had hepatitis C. And I was junior researcher. I was 27 or something. Had a little poster at a hepatitis conference, and the person next to me was presenting about stigma in people who had both HIV and hepatitis C. And that in that particular cohort of people, it was perceived to be more stigmatizing to have hepatitis C than it was to have HIV. And that was in that particular group of people. And that was a real eye opener to me, that there were these, different different levels of stigma, and that they are fluctuating and change in different social contexts and across the lifespan. And I think that is also the same thing a bit. So we talk about autism. That paper was about autism, but we know that autism and ADHD occur just as often together as they occur alone. But for different people in different contexts, attitudes towards autism may be completely different towards attitudes towards ADHD. And it's a bit of a minefield, really, in terms of stigma and of understanding. And I think, our understanding of autism has changed substantially since the last DSM. Who knows what the next one will bring? But it's also important to understand the history of the DSM. Going back to the history all the time, homosexuality was in the DSM until the late 80s, and it is obviously no longer. in the DSM.
Yeah, that's so interesting what you said about biomarkers and how they change because, of course, right now we're approaching the road to 2026, the evolution of the diagnostic criteria for hypermobile EDS, and that's causing a lot of stress in the community, a lot of angst, totally understandably. But it's so helpful what you were saying about labels and how they're constantly changing. These biomarkers are changing. And that really, at the end of the day, what we should be looking at is how can we help people feel better, function better, and things like that. And try, even though labels are very important because they give us access to things like more physical therapy sessions, more specialists, and things like that. So labels are still important.
No, they
But
absolutely are. We need labels to count things, and we also need them to need them to code them in your insurance system so that they can be paid for. And you need them. Sometimes they're a gateway. You can only we can only really prescribe ADHD medicine if you have a ADHD diagnosis. They do serve a function, but people are so much more than their labels, and labels are always changing. But the pattern isn't. As I said, you can see that pattern in there's this wonderful description in Shakespeare of I think it's in Hamlet where he says, "Wherefore I know not, I have lost all my mirth," which means I've lost all my happiness. And that is and it's like what, sterile promontory, this earth, this quintessence of dust. And that is, a real description of anhedonia, which is one of the things that we conceptualize as a core feature of depression. And that's been around in literature forever. I am sure the pattern of neurodivergence and also the pattern of hypermobility have been around forever. They will have no doubt, and I think some people have certainly written about this in terms of ADHD and autism. I don't know if they've ever written about it in terms of hypermobility, but there will have been an evolutionary advantage to being the type of person who could reach the berries on the strange trees, or the type of person whose physicality meant they could run, a particular distance. So that there will have been an evolutionary advantage to being built differently and to being thinking differently. And these patterns have always been there. It's just that we have called them different things over different times. So, Linda, one of the things that really came to mind when thinking about the sort of neurodivergence personality disorder overlap is the Scandinavians. They're in a meta-analysis. So meta-analysis are where you kind of pool lots of data from different sources. A paper looked at all of the medicines that are used by psychiatrists for the treatment of borderline or emotionally unstable personality disorder. And the interesting finding was that ADHD medicine was the most effective. So, could be ADHD medicine is effective in treating emotionally unstable personality disorder. Could be that a lot of people who have a diagnosis of emotionally unstable personality disorder actually have ADHD. Or it could be that, as I said about, ADHD, EUPD, and bipolar, that impulsivity and emotion regulation difficulties are the core features, and those are amenable to stimulants.
that's so fascinating. And when I think of stimulants, I think of them helping people with focus, but does it also help with the emotional dysregulation and impulsivity?
Yes, it really does seem to be a significant benefit. And also, interestingly, some people, obviously, this is with the appropriate medical advice, some centres use stimulants in the treatment of postural tachycardia syndrome because of the vasoconstrictive effects of stimulants. So, yeah, we're always learning new things. And there's been in the moment in the UK, there's a bit of controversies about, what is the prevalence of ADHD and autism? Why is there so much demand for diagnostic assessments? How can our healthcare system cope with this demand? And one of the really interesting, and there's a lot of chatter about this idea of overdiagnosis, which I think is not helpful. But really important thing is there was this study published last year in the BMJ by Zheng et al., who showed that ADHD medicine reduced, this is particularly stimulants, reduced death by suicide, criminality, substance misuse by about 20% across the board. So ADHD medicine is generally safe. I mean, loads of studies that suggest that. And its effectiveness is hard to beat amongst other. I mean, you can't do direct head-to-head comparisons, but in terms of the interventions that exist in medicine, I think we published in a paper called The Elephant in the Room, Neurodivergence in Psychiatry, that the number of people needed to treat with ADHD medicine is 3, which in the grand scheme of medicine is actually a very good number. And the tools, I'm not saying ADHD medicine or stimulant medicine is for everyone, but it can, supporting people with ADHD and neurodivergent people can really save lives. And it's important not to trivialize the difficulties associated with ADHD and autism.
I really appreciate you sharing that because I feel like there is, speaking of stigma, a lot of stigma about the treatment and taking stimulants and, do you really need that? And I mean, I'm guilty of it, that actually myself with family members at times. Well, do you know that you still need that? So I really appreciate you sharing that. Very important information. And we'll find that Yang et al. Paper and link that in the show notes. Also, about the stimulants and POTS. So many people think of POTS, postural orthostatic tachycardia syndrome, as like the tachycardia being the problem. So a stimulant would make the tachycardia worse. But that's fascinating that it actually can be beneficial in this group of people that suffer from fatigue and chronic pain and so many other things. We know it's a dysfunction of the autonomic nervous system and not just a cardiovascular problem.
I mean, and obviously you must talk to your medical professionals, but there are also, that's the other thing about medicines. They're not anti-anxiety medicines, anti-ADHD medicines. They all have these biological pathways that have all sorts of downstream effects, and they don't all work for everyone, but working out who benefits from what is really, really important.
Yeah, that's great. And we are going to definitely have a part 2 of this conversation because we got about halfway through my questions that I wanted to ask. So we're going to come back and talk about some of the other things that you've spoken about: chronic pain, fatigue, self-harm, which you alluded to, but I want to talk about that more for sure. Before we get to the hypermobility hack, which is how we end every episode, I just want to ask, I love that you talked about the diving reflex and cold on the face, and so that we can leave people with something that they can try. So you talked about proprioception, working on proprioception as a way to reduce that, uncertainty in the body and that proprioceptive surprise. We can use things like compression garments or exercising in the water, or like you said, any kind of tactile cues that way. Do you think also that other things that stimulate the vagus nerve can help with that emotional dysregulation? So like humming, gargling, singing, are those things that might help as well?
I think humming probably does. I am a little wary of all of, when you're scrolling your phone, there are all these things that claim to be hacking your vagus nerve, and I think we have to be, pretty evidence-based when thinking about these things. But yes, absolutely, using your own autonomic nervous system to regulate is really important. And one of the other things that Hugo and I were discussing, he was telling me about the diving reflex, is you wouldn't realize it, but there's another reflex. I can't remember exactly what it's called, but basically, menthol helps you concentrate. And that is not my hypermobility hack, but it is food for thought. My hypermobility hack is, as I mentioned, I'm experiencing a lot of musculoskeletal problems at present. One of the things that I tell my patients and I tell myself is do not underestimate the importance of arch support. So, a lot of hypermobile people have flat feet, and having flat feet can have a huge knock on effect throughout the body. And something simple like an inner sole with arch support can actually make a huge difference to neck pain, back pain, hip pain, and a general feeling of stability. So my hypermobility hack, which is keeping me going at the moment, is a combination of arch support inner soles and incredibly strappy high top trainers to keep my ankles together.
I love that hack, and I pulled off my shoe because I am wearing these OOFOS, which it might not look like that much arch support, but it's enough that it makes all the difference. I had so much trouble with my feet. I was actually went on a family trip a number of years ago, and I was in a wheelchair because I couldn't walk enough for the activities that we were gonna do, which were not that much, by the way. And so my family was pushing me around on a wheelchair because I had so much difficulty with my feet, and now I'm doing so much better from a variety of things. But yes, love that about the arch support and really paying attention to your footwear, your ankle support, and everything. That's great. I love that hack. Before we go, can you tell people where they can learn more about your amazing work?
Yes. So I am Dr. Jessica Eccles, and you can find out more about my work or our work, because this is a huge team of people who are involved in this, on my link tree, Bendy Brain, and also YouTube channel, Bendy Brain. And I'm on Instagram as Dr. Bendy Brain. So please try and keep the link tree regularly updated. You can subscribe for alerts. And yes, do check out the YouTube Bendy Brain and Instagram Dr. Bendy Brain. And also I'm on LinkedIn as well. But I'm really looking forward to speaking to you again soon, Linda. And still have fond memories of meeting you in person at that IADMS conference in was it Ohio in 2023?
Oh, yes, it was. I was telling somebody that it was Montreal, but no, you're right. It was Ohio.
It
Montreal
was
was in
Ohio.
2019. It was Ohio.
Yeah,
Yes, you,
yes.
Jennifer Milner, and I all had dinner together, which was wonderful. Jennifer Milner was my co-host for the first, like, 4 seasons of the podcast, and now I still do lots of other activities with her. So she co-hosted when we interviewed you both times, I believe. And so, yeah, we had a great, great dinner, fascinating. I just love everything that you're doing, and I'm so grateful to you for taking the time to talk with me. And I love how we have a picture together. In fact, I'm gonna have to share that with the social media team so that they can
Yes, yeah, we
use
have
that.
with both of I think I've got a zebra jacket and you've got a
Yes.
zebra yes,
Yes.
yes, we've got
Yes.
that photo. Yes.
Yeah. We're side by side. You're wearing a zebra jacket. I'm wearing zebra pants. Together we have a zebra suit. So, yeah. And I'm bendy bodies and you're bendy brains. So it's perfect.
Exactly.
Wonderful, wonderful. Well, thank you so much. I know that you're super busy and you're doing such fantastic work. And I love how it just ties so many different things together that impact and touch so many lives. I mean, if you think about between the diagnosis of, borderline personality, autism, joint hypermobility, if you think about all the different things, anxiety, all the different areas that you're touching, this is like most of the population of the world. So you're
Oh,
really,
yes. And
yeah.
I do really want to be clear that although we're talking about what you think of as psychological phenomena, I do think there's a brain body basis to all of these. And yeah, that one of the biggest problems is not only finding the right framework in order to be believed, is also bridging that gap between the brain and the body.
That was the opening question because you used Slido at the IADMS conference, and your opening question, I believe, was, do you think that the brain and the body are really separate, or that the conditions should be considered separate? Something like that. You asked a
Yes,
really
yeah, yeah,
great
yeah.
opening question. Yeah.
Yeah, the big idea. Yeah.
Yeah. The big idea. Okay. Well, thank you again, and I look forward to chatting with you next time.
Thank you, Linda.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at hypermobilitymd. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.